Hello, my name is Cameron Lee, and I am a classification manager at the Independent Hospital Pricing Authority. And alongside me is Josh Girodi, director from Taylor Fry. Today, we'll be presenting on how statistical modelling can be used to recalibrate classification complexity models, in particular focusing on the Australian Mental Health Care Classification and the Australian Emergency Care Classification. IHPA develops classifications to provide the healthcare sector with a nationally consistent method of grouping patients based on the care received and the associated cost. This is in order to enable activity-based funding across the Australian public hospital system. The Australian Emergency Care Classification was released in 2018 to better account for patient complexity and cost variation for emergency department presentations. The classification has a three-level structure. Level 1 splits episodes where visit type and episode end stats values are used as the main classifying variables, and those where diagnosis is captured. Level 2 clusters episodes into major clinical conditions managed in emergency care settings. These groups are called emergency care diagnosis groups. And Level 3 is where emergency care diagnosis groups are partitioned into N classes of different levels based on complexity. And this is the area focused on in today's presentation. The Australian Emergency Care Classification calculates an overall complexity score for each presentation from a set of predetermined coefficient values. For each emergency care diagnosis group, every variable has a unique coefficient value, which is summed and rescaled to generate an overall complexity score. This complexity score is then compared against an upper and lower threshold, which results in the final N-class grouping. Comparatively, the Australian Mental Health Care Classification was released in 2016 and is a clinically relevant classification that better explains resource consumption at the consumer level. The Australian Mental Health Care Classification has 6 major splitting variables. The first 3 are categorical variables, which are setting, phase, and age, and the remaining 3 variables are complexity variables, which are mental health legal status, health of the nation outcome scales, and LSP. As you can see in the diagram, there are specific variables for each setting. However, the focus for today's presentation is on the health of the nation's outcome scales, which is also referred to as HoNOS. This is a clinician-rated instrument comprising of 12 simple scales measuring behavioural, impairment, symptoms, and social functioning. Under the Australian Mental Health Care Classification, each HoNOS item has an associated weight. The scores from the measure are multiplied by the respective weights and subsequently added together and rescaled to calculate an overall HoNOS complexity score. Similar to the emergency care classification, a score threshold is then used to split phases into moderate and high HoNOS complexity. The Independent Hospital Pricing Authority undertakes reviews and updates of existing classifications on a regular basis to ensure that they are aligned with changes to services and to resource consumption over time. When doing this, a number of factors are taken into consideration. As outlined from the previous slide, a key component of the emergency care classification and the mental health care classification systems is determining clinical complexity of a patient episode or phase. This is determined by using a proxy measure, which is cost. This is used as more complex episodes or phases tend to be more costly. Additionally, changes to the delivery of care result in changes to the cost of care, and this needs to be taken into consideration. The classification's complexity models originally developed from the 2016 Emergency Care Costing Study and the 2014 Mental Health Care Costing Study, which collected data from 10 and 24 hospitals respectively. However, due to improved quality and coverage of both emergency and mental health care data nationally, the Independent Hospital Pricing Authority determined that there'd be benefit in reviewing these models and engaged Taylor Fry to recalibrate the emergency care complexity model and to concurrently review and update the HoNOS weights used in the mental health care classification. I'll pass over to Josh now, who will go through the design of the complexity model update and the improvement that has been found.
Thanks, Cameron, and hello everyone. I'll first discuss the approach developed for updating the Australian Emergency Care Classification. The model is comprised of a set of unique coefficient values for each emergency care diagnosis group, which relate the risk factors present for an emergency care presentation to the complexity score, and a set of thresholds which are compared to the complexity score to determine the complexity group and so the N class. Updating the AECC model involves updating these coefficient and threshold values. When designing the modeling approach, we adopted criteria to ensure the models were fit for purpose. These criteria relate to the model's performance, stability, flexibility, transparency, and computational efficiency. Occasionally, these criteria conflict. In particular, when updating a classification such as the AECC, consideration must be given to the important trade-off between the responsiveness of the classification to new experience and the stability of the classification through time. If we allow the model to respond more strongly to emerging experience, then necessarily the classification complexity model will have a greater degree of change between versions, meaning it is less stable. Conversely, prioritizing the stability of the classification means we must be willing to fit less closely to the newer experience. There's no single optimal balance, and so the update methodology has been designed to provide IHPA the flexibility to choose the right balance when performing the update. This is achieved by providing three approaches to updating the model. The first we refer to as an independent update. This approach calibrates solely to the latest experience and so is the most responsive to change. We also provide two anchored update approaches that, as the name suggests, anchor the model to the existing classification, improving the stability. In all cases, the complexity score is calibrated using a set of linear models and the complexity group thresholds are determined as the optimal threshold values accounting for business rules. Recalibration using the national data showed that all approaches performed well, with a relative improvement in performance of approximately 2% compared to the AECC version 1. There was very little difference in performance between the different update approaches. The anchored updates improved stability, reducing the number of episodes changing N class by up to 75%, while relative performance reduced by less than 0.1%. For the Australian Mental Health Care Classification, we assessed the effect of recalibrating the HoNOS instrument weights and N-class thresholds using national data. The modelling considerations were largely the same as for the AECC, and so we utilised the same modelling methodology as a result. An additional constraint was added to the models to ensure that the weights for all HoNOS instruments were non-negative, meaning an increase in the score for any HoNOS instrument could not result in a decrease in the calculated complexity. We assess the performance using the area under the gains ratio statistic. The area under gains ratio is a measure of how well the model is able to sort phases from lowest to highest complexity. A value of 100% indicates perfect ordering and 0% indicates random ordering. The chart at the top right shows the performance improvements for the admitted setting. The existing AMHCC version 1 HoNOS weights contribute 2.7% to the gain statistic for the classification. This is a material contribution. However, recalibration of the HoNOS weights using the national data increases this contribution by a further 2 percentage points. In relative terms, this is an 80% uplift in the contribution of HoNOS. The chart at the bottom right shows the performance in the community setting. Here the contribution of HoNOS is more modest, with a 0.1% benefit from the AMHCC version 1 HoNOS weights. Recalibration of the weights adds a further 0.4%, a substantial increase. We can now pass back to Cameron, who can provide a summary.
Thanks, Josh. Complexity models and thresholds should be regularly refined as patient characteristics and associated costs vary over time. Updates to the emergency care classification and the mental health care classification complexity models demonstrates that improvements to performance can be made with limited structural change. As a result of this, we plan to undertake extensive consultation with stakeholders to determine the feasibility and appropriateness of updating these classification complexity models in the future. Thank you very much for listening. There's more information that can be found on the IHPA website, and there are plenty of ways to stay connected. If you're interested in finding out more about these specific classifications, please don't hesitate to get in touch with myself, or if you're interested in undertaking similar work in the future, then please feel free to reach out to Josh. Thank you very much.